I'm going to show you how you can use precision medicine, gene expression profiling, to help you manage. In this talk, it's going to be cutaneous melanoma. I'm in private practice at Bayer Dermatology in Dallas. I'm also affiliated with Baylor Scott and White, and me and Clay Cockrell are trying to start a residency down there too. So hopefully that will be the next one for my talk. I am an investigator and an advisor for Castle Biosciences, which is what we're going to be talking about today, amongst another test as well. What are we going to be talking about? Melanoma staging, real quick. You guys already know this. Talking about our patient management, and then we're going to talk about the 31 GEP, the Decision DX Melanoma test, so you know what I'm talking about, and how you can incorporate that into your management. Now, many of you have already heard about this test, so I'm not going to try to bore you with all the basics. I'm going to try to hit what's new, what's different, what really matters. If you have other questions about, the nitty-gritty data, statistics, what have you, you can have my personal email. I'll be over on the side, happy to talk more. So this is current staging. This is AJCC. You're all familiar with this. And this is what the NCCN tells us on how to manage these patients. If they're thin melanomas, like stage 1A or 2A even, what does it tell you to do? You'll see your patient back every 6 to 12 months. So I already know that you're not following NCCN guidelines to the T, to the book, right? Because we're all modifying our management based on every patient's individual risk. And that's really all we have to do for these low-risk melanomas, according to NCCN. When you get into the thicker melanoma side of things, a little more concerning, your risk obviously goes up. You're going to do a little bit more. You're going to see the patient back more often, but you're also going to consider other procedures like sentinel lymph node biopsy, imaging. There's lots of other management decisions that we have to make. One of those is, do you send your patient out for a sentinel lymph node biopsy? That procedure is primarily guided by how thick the melanoma is. Let's be honest, that's the T staging. And these numbers come out to be a nice even number, 5, less than 5%, between 5 and 10%, and greater than 10%. But this actually comes from very large data, the MSLT1 trial, for example, that really helped guide you, hey, this is now risky enough, you should consider a sentinel lymph node biopsy procedure. But in comes genomic testing, and that's the 31 GEP. Again, this one is the Decision DX Melanoma one from Castle. It looks at 31 genes. As Dr. Ferris was telling you, you've got this training set that you then develop your test on. That's what was done here with 31 genes, and then you have to validate it on a whole nother set. And then you have to validate it again and again and again to really prove that it's working. And that's what this test does. It outputs different class calls. It's binned class 1A, which is very low risk, 1B, 2A, which is this intermediate zone, and then class 2B, which are these really high-risk patients. But what's very cool about this technology and just the whole field of precision medicine is that it's only gotten better with time. And so some of the biggest critics of this sort of testing, of this sort of data and information was, well, hey, I want this given to me on a full threshold from 0 to 1, because that's what the GEP score actually is. And so here you can now see the threshold on the right is 0 to 1. And so what the company did is said, okay, let's make it even better. And even beyond just giving you that threshold of risk that Dr. Ferris was kind of talking to you about, instead of binning it as malignant or benign, it's kind of across an entire threshold. That's my song. Is that they now incorporated it with clinical pathologic features. This is what we're already doing, right? This is how AJCC works. You look at some of the clinical factors, such as age, and then you can also look at some of the pathologic factors like Breslow thickness, ulceration, and even mitotic rate. Those are already factors that we think are important. Well, now they incorporate those factors with the GEP score to get your patient's unique and specific, their personalized risk. It's their risk of having a positive sentinel lymph node, as well as their risk of having the cancer come back. either a recurrence, a metastasis, or unfortunately a death. And so now you have this I-31, this integrated 31 report that will tell you your patient's specific numbers, which can then help change your management. So here we are. You've already done your various device that Dr. Ferris has told you about. You know you found yourself a melanoma. This is the patient that's sitting in your office, and you want to prevent them from being on the left side, moving over to the right. Metastatic melanoma that we all know is not going to go very well. And so when I have these patients, you're already thinking about a couple of different management questions. What's their odds or what's their risk of having a positive sentinel node? Why do you care about that? Well, depending upon that risk is whether or not you're going to send them to your surgical oncologist. And I would argue that, I did actually plastic surgery before dermatology, so I've done many sentinel lymph node biopsy procedures. And even though many of us here in dermatology world may have not done a sentinel lymph node biopsy procedure, I would urge and tell you that you are the gatekeeper. In other words, if you send them off to surgical oncology, we all know that if a doctor has a hammer, everything becomes a nail. And that's not the case for every doctor, but oftentimes that can be the situation. And so you really are the gatekeeper, and you have to consider who and when and where you're sending your patients. And then the other question is well, what's their risk of recurrence? What's their risk of dying? All those matter because if they're high risk, well, you're going to do a lot of things for them. Increase your management. If they're low risk, well, maybe all you have to do is cut it out, and that's it. Goal, though, is that you want individualized, personalized care, and that even is what the, here you can click back here, the NCCN guidelines recommend. You really want to individualize this care. So let's talk about sentinel lymph node biopsy real quick. So here you are, you're thinking about doing a sentinel node, and I told you, well, we're going to follow NCCN, and they said, okay, if it's less than 5%, that you should not do this procedure. So what does that risk really mean? And just to give you sort of a pictorial version of that, if you had 20 patients that otherwise you could do the sentinel lymph node biopsy procedure on, but you're not going to do the procedure. What that looks like is that, well, you were right 19 of the times. That's pretty good. But there was one patient that you would have missed, right? They would have had a positive node. Had you done a sentinel lymph node biopsy procedure on all 20 of those patients, well, 19 of them would have been negative, correctly, but one of them you would have actually found. But you're okay with this 19-to-1 ratio of missing. That is what 5% looks like. And why I bring that up is the thinking is, well, if we're going to do anything different, we got to beat this score. We got to be doing better than that. And I'm going to show you how you can do that with gene expression profiling. Here's what the test does. It takes these clinical pathologic features. The company did look at a lot of other features. These are not the only ones. These are just the ones that were statistically significant. And then you'll get your patient's precise risk of having a positive sentinel lymph node. Here are the statistics on it. Basically, they're all very good. Here's the paper on it. You can snap a quick photo. Again, we can go into the details of this paper. But before we go into that 19-to-1 ratio, I want to introduce you to another test. There is another gene expression profile test out there. This one is from Skyline. It's a company over in Europe. It's an 8 gene expression profile, and it's 8 GEP plus CP, the clinical pathologic features. It includes Breslow thickness and age. So when they developed this assay, they actually developed it with those clinical pathologic features. The reason why I bring that up and why I think it can be an issue is this is their data showing their clinical their GEP model and the clinical pathologic features just by themselves. That's the lower 2 lines. That's what you get with that. And then when you do their clinical path features with the GEP, it improves it. So it does do better. The assay does help and improve our accuracy. However, the question is what's actually giving that lift? Is it the actual clinical pathologic features? Is it just a very expensive test that's this clinical path features are telling me already? Or is it the gene expression profiling? The other thing I'll mention about this test is it is it's really kind of just an assay at this moment. There are a couple of large academic institutions that are studying it, one in particular, the Mayo Clinic, which is heavily invested in this test. So let's compare the two side by side, and there was actually a recent publication in Skin on this one. So on the left side, you got 187 samples for the 8 GEP test, and on the right, 763 for the I-31. And this study for the 8 GEP, this was their only US study, and I think this was also their best data. So this was them on a very good day. And you could see with the N, the true negatives and the false negatives, 177 to 10, only gave you a 17 to 1 ratio. So unfortunately, didn't quite beat that 19 to 1, which is, as we know, our standard of care. Looking at the I-31, though, you can see that, hey, there was actually an improvement of 30 to 1. So at least we know that if we utilize the I-31, it's not perfect. You still have false negatives. Every test does, but at least we're going to improve upon what we're already doing. And what's also cool is that, there is some new controversies in the melanoma world. Those same people from Mayo that used to say, hey, look, less than 5% is kind of your benchmark. Well, actually, we're going to move it to 10% because 5 to 10 is actually just only considering a sentinel lymph node biopsy. Well, what's cool is that because you're getting precise numbers out of the I-31 GEP, you can actually adjust your risk threshold from 5, 6, 7, 8, 9, whatever percentage you want to consider for your patient, and then you can see, are you actually going to beat the standard of care? And each and every time you do that. Unfortunately, with the 8 GEP, because it's a binned result, you can't do that. But don't just trust me, trust Dr. Marchetti. He's a guy from Memorial Sloan Kettering, very well known in the melanoma space, and he had a variety of he was involved in a variety of dramatic articles in JAMA Derm that kind of criticized gene expression profiling. What's really cool, again, is that this technology continues to get better, and it's the critics that actually make it better. And so a year later, he now did a utility model looking at the I-31 GEP. And essentially what he found, that using this relative utility model, which he developed on his own, you can actually see anything that was positive was actually significant. And it's really a bin thing. So anything that was positive. So essentially utilizing the I-31 for T1Bs all the way up to T2Bs was significant. The T1As with high-risk factors was close, but didn't quite make it. But I would still argue that a T1A, the way this model is set up, you're either going to do a sentinel lymph node biopsy on everybody, or you're not going to do it on anybody. And the reality is as human beings, as doctors, we don't treat patients that way. It's not all or nothing. We kind of modify what we do with these patients. All right, so let's focus on prognosis. This is maybe one of the most important slides I can show you. The company had worked with the National Cancer Institute, the NCI. This is the government. This isn't the company. This isn't, there's no bias in here. This is the SEER database, which is the best we will ever get when it comes to data for the United States. We're not a socialized healthcare system, so this is really the best data you can get. And little did we know that the NCI was actually following this test and its outcomes. And so they looked at over 5,000 patients that actually had the I-31 GEP test done, and they wanted to see, can this test actually stratify like the company has said that it can? And the answer is yes. But what's really cool is that they also then compared them to patients that did not get a GEP test. And they wanted to know, was there any difference? And they used all the different covariates, so they matched them in every way possible that the National Cancer Institute can do. And they found that you were 27% more likely to live. You were 27% more likely to live if you had a GEP test done for your melanoma. Now, does that mean if you order the test, it's going to help your patient live longer? No. It's you. It's you that's actually helping these patients live longer because you're changing your management. And there's a whole chain of evidence now that really shows that you can do that. Real quick, just to kind of compare it to another oncology field, breast cancer. We use GEPs and molecular testing in lots of other cancers. Skin cancer and dermatology is a little bit slower, later to the game. Just to give you an idea, for breast cancer, Oncotype DX showed a 0.5% improvement in their big study, and that is now used for all the breast cancer patients. 31 GEP had over a 1% improvement at just 3 years. Basically, if this was an FDA study for a biologic, the FDA would have come in, stopped the study, and said, hey, look, everyone gets the intervention, everyone gets the treatment. So can we get even more precise? Yes, we can actually figure out what is your patient's risk of recurrence, whether if they're going to have a metastasis, or whether they're going to live or die. And these black dots are what AJCC shows us, and then these are where the patients actually get stratified. And this is what's happening to you when you have patients that you think are low risk, but actually end up having an event, a metastasis, or you have patients that are actually very high risk and go on to be fine. It's just the nature of our staging systems that bin, but the reality is you want to know your patient's personalized risk. So I use GEP first to figure out what I'm going to do for sentinel node, then what sort of management I'm going to do afterwards. There's papers out here that can help you integrate this test even further. Thank you so much. I'm a minute over, so hopefully I'll get invited back. Thank you.